Finally, it is my honor to recognize the last speaker on this morning's panel before the break, and that's Senator Bill Cassidy, who's our senior senator from Louisiana, who serves on health education, labor pensions, energy and natural resources committees, finance, Veterans Affairs, and joint economic committees. And in all the spare time, and before getting into that role, he co-founded the Greater Baton Rouge Community Clinic. He is a person who has been on the front lines of delivering care to those that are among the neediest in our communities, and a clinic providing free dental and health care to the working uninsured. But I'll tell you, as a researcher and as a research vice president, he is a researcher's dream because he is one who understands the value of research and innovation that we do in our universities and our laboratories across the state and across the country, and how they really need to transition into the marketplace in order to help save lives and impact population health in one of the most meaningful ways. I think it was for the first time in the history of the state of Louisiana that I saw the three national leaders for the National Science Foundation, the National Institutes of Health, and FDA all being convened at a meeting about 2 years ago for the first time in my history of 25 years of being a Louisianian, that these three leaders were in Louisiana, talking about what we do in Louisiana and what research is coming out of our universities and how our federal agencies need to partner with us in helping improve population health in a state that so desperately, obviously, needs that improvement in healthcare. So thank you, Senator, for leading from the front, and with that, over to you, sir.
Hey, thank you all for having me, Ramesh. Thank you for that nice introduction. And my hope is that first, what is my role here? My role is hopefully to give you some of the information that you can use to find solutions that will help do something about the opioid epidemic. And when I first thought I'm coming to the Cajun Code Fest, I had to start kind of imagining just the potential that is here. Now, I'm a physician. You may know that. I'm a gastroenterologist. My standard joke is that gastroenterology prepared me very well for politics. If you're over 50, you get the joke. If you're under 50, just you wait. On the other hand, it does help because it gives me a perspective of mental health and the related issue of opioid addiction. In 2016, I worked with Senator Chris Murphy of Connecticut on the mental health bill of 2016. And I noted if I went to an affluent neighborhood in Louisiana or if I went to one which was less well off. And I started speaking about how mental health issues, serious mental illness, touches us all. In my case, it's my family. In your case, it might be as well, but it's at least a close friend, somebody you went to high school with, who you noted at the time there was something different about her, but it was only later that you learned that her marriage broke up, her kids were in foster, she was perhaps homeless, and you now recognize the role as serious mental illness. And wherever I was, whether it was the Martin Luther King Center in the Lower Ninth or a well-off suburb in Lafayette, Louisiana, people would nod their head yes. It cuts across. Now, unfortunately, I can also say that's true of opioids. Each of us has been touched by someone we love in our family or among those whom we know who have been touched by opioids. But unlike serious mental illness, it is not something which will occur and we recognize it 20 years later. It's something which we see now. We see it at the obituary. We see it at the funeral we attend. We see it at the tears of someone we know who just lost their child, their grandchild, their spouse, their partner, their brother, their sister. And just as I said, it cuts across. No matter what setting to which you speak to this, there is a head that nods yes, there is an eye that tears. So our challenge is, what can we do about it? My hope, and I'm flipping down to my notes, give me just a second, is that we can use this sort of forum to find a solution that makes what I just described less likely to occur. Now, let me give you a little bit of a framework of the problem and where big data or some other intervention can make a difference. We have drugs being written by two types of physicians that are a problem. One is the pill mill, the physician that rolls between state to state to state. You walk into his practice, you give him $500 for a 5-minute physical, and you walk out with a handful of prescriptions. That's one problem. The other is what Dr. Gee just referred to. It is the well-meaning physician who doesn't want you to hurt. And statistically, we know that if you have two ER physicians working in the same emergency room, seeing the same type of patient, say a sprained ankle, some of them will write a 30-day supply, and the other will write a 3-day supply of opioids. Now, statistically, there's going to be somebody with a genetic predisposition to addiction that if she gets that 30-day supply, she will end up her 30 days as an addict. Not because she intended to, and not because the doctor was not well-meaning. Indeed, you could suggest he was too well-meaning. But the point being that the overprescription is what caused the problem. Now, everything I've said so far is replete with opportunity for big data. I see Ramesh over there nodding and said yes. Oh yeah. Because we have, and Dr. Gee referred to it. If you talk about the pill mill doctor, we have something in every state, or almost every state, the prescription drug monitoring program, where every physician writes down his or her unique identifier so that if I give you, ma'am, a prescription for opioids or Valium, you take it and you fill it, and they log in that Bill Cassidy, your gastroenterologist, wrote you for this medicine. And a pharmacist enters it, and other physicians can then look at it. Well, wait a second. This patient has picked up prescriptions from 10 other doctors. That's not right. Or law enforcement. It can be referred to law enforcement. And law enforcement can say, here's a doctor writing for lots of prescriptions. He's not a cancer doctor. She's not a pain doctor. It's a family practitioner who, wait, let's look at this, was previously in Georgia, Alabama, Mississippi, always one step ahead of the law. Now that's the power of that. Hats off to our medical society. We're one of the few states that proactively shares that with law enforcement. Saying, hey, law enforcement, we've identified a problem, need to do something about it, and law enforcement sweeps in. But, by the way, DEA has not been doing this. DEA has been so focused on illegal drugs coming across the border that they've not focused upon the legal prescriptions that have been written here inappropriately. That has changed. Jeff Sessions, who is the Attorney General, of course, about 3 months ago announced that they were to begin doing this, and they would begin using this sort of a database. But let me tell you the limitations of that data. Imagine you're in Shreveport. You can go to the VA, and you can go to a private doctor, and you can go to Arkansas and Texas all within one day. Potentially picking up prescriptions that would not be detected because Louisiana doctors may not know what the Arkansas doctor is doing, what the Texas doctor is doing, what the VA physician is doing. The VA is supposed to integrate their data. In about 17 states, I'm told they've not yet integrated their prescription data into the PDMP. We have an opportunity for big data. We have the opportunity for someone who knows how to figure out that system to do it better. Some already have, but we've not yet adopted that. One more problem. If I get my 5 prescriptions from the pill mill and I go and pay cash, that PDMP may not register that data for a week. And by that time, I've gotten it all. Okay? Now that's a problem. And we have to work through that. But let's just not stop there. We've been talking about the legal supply. Let's talk about data applied to the illegal. When I ran for politics 10 years ago, my hair was the color of David's. Now I tell my children it's platinum blonde. But in 10 years, it's this sort of thing that has given me gray hair. Actually, it's teenage daughters that have given me gray hair, but aside from the teenage daughters. Mexican drug cartels reportedly generate $110 billion a year from illegal drug trade, which they transfer to Mexico. 110 billion with a B. The federal government manages to seize 7 billion of that. we're getting less than 5% of all the dollars generated by illegal drugs. How do they move the money south? Trade-based money laundering is one example, where somebody has a good in Mexico, the manifest says that it's a cell phone. Now, it could be a smartphone worth $1,000, or it could be a flip phone, or it could be no phone at all. It is a double manifest. And they use that arbitrage, that kind of, okay, this is what we tell you we're shipping, so therefore we're going to spend that much money. In reality, they just shipped $1 billion down for $500 worth of material, or maybe fictitious material. We need to do a better job tracking trade, because that's neither supply nor demand, that's financing. And if you can take care of the financing, we would stop the illegal drugs moving here. That, as Dr. Gee speaks of the decrease in legal, that void is being filled with illegal. And that's all data. That's all data. How do we get federal agencies and companies to better cooperate and better analyze so that we know that data coming, we know those goods coming across are real and they've been valued appropriately, and the money moving south, we've been able to track it, and so we know it's not laundered money, rather it's appropriately done. One more kind of data-oriented solution I wish to mention. Dr. Gee spoke about treatment programs. So we've talked about the supply, and we've talked about the financing. How do we decrease demand? Well, you decrease demand by treating people and keeping them in recovery. But when I have a committee, and there's folks here from the treatment community, and I say there's some of you, treatment facilities in general, that do fantastic work, and that somebody comes through that treatment facility and she is most likely to stay clean, or much more likely to stay clean. And there's some that are just mills, that they come through, they get their check, but there is a high, I see heads nodding over here. There is just a constant sort of, you're right back in, someone's pocketing a check, but it's a rip-off of the taxpayer, and it's no good done for the individual who's going through the treatment program. We need to analyze that. We need to use our data to understand, wait a second, you go through here, and you're less likely to be seen within a year for a opioid-related event in an emergency room, or you've been seen here, and as best we can tell, you're being readmitted, you're showing up in the emergency room, you're needing Narcan, boom, 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 boom. So on the treatment side, the decrease the demand side, that is another effort that we have to come to. There's many other issues as well. We have an initiative that we are rolling out, and we call it the Safer Families, Healthier Communities. And we attempt to touch each one of these facets. I'll mention some because, Lauren, raise your hand. Lauren Casanova works for me. She works for you. She's employed by your federal tax dollar to be the representative of this Senate office that I have the honor to hold temporarily. And if you need something, grab her card. I think it has her cell phone. She's not married. Call her up anytime. She's available, she loves to hear from you even if it's at 3 in the morning. She's in Crowley. She's a local girl. She'll do great. So that said, some of the stuff that we've been able to do that I just want to mention. We passed the Comprehensive Addiction Recovery Act, the Cures Act, which puts the Emergency Medications Act. We put those all into law, and last month appropriated about $3.6 billion more than the billions appropriated in those dollars to fight the crisis. We've asked the General Accounting Office to do a review of the Foreign Narcotics Kingpin Designation Act, the folks running the cartels, how well is it working to capture them and to break up their activity. And we're also looking at federal government efforts, the effectiveness to stop gang activity and gang violence. We've been pushing the DEA to use big data in order to more effectively track which physicians are prescribing drugs in a way which is inappropriate. We've asked the U.S. Department of Education to come up with an education program to bring into our school systems so that when a child begins in the first grade, she or he throughout his years is learning the danger of opioids, just as I once learned the danger of smoking. That is our new smoking. We've introduced legislation again to stop pill mills. We've introduced legislation to increase the penalties for fentanyl distribution. Another $1 billion for prevention, enforcement, treatment, and recovery programs, trying to secure the border to stop the flow of illicit drugs and money laundering, and again, aggregating big data in big time. But that said, all this is just making resources available to you. None of this will be successful without you. I thank you for being here. I thank the organizers of the conference. If there's anything we can do to help you serve those folks so that 5 years from now we don't need to have this conference because the issue of opioids has been addressed, that may be too much to hope for, but it's a great hope to have, and many people's lives depend upon us as much as possible fulfilling that hope. Thank you very much.